Mobeen Sayed from drbean.com. Welcome to one more show. So, the discussion today is very interesting. I had been actually waiting for this kind of a study for some time. This study represents or presents a meta analysis of other studies. And now, please remember when we are looking at meta analysis, usually there is a lot of um, the strength is not as good as a straightforward study. However, there are many uh, statistical and mathematical ways to improve that strength. So, in today's discussion, they have actually picked up hundreds of studies, actually thousands of studies, and then watered them down to 68 studies that they have looked at. Out of those 68, I believe some of these are preprint. The data that they wanted to collect, and this is a Canadian study, data that they wanted to collect or understand was people who are vaccinated, mRNA or J&J or adenovirus, they have not covered inactivated virus vaccines because they didn't have that data. For the mRNA and adenovirus based vaccines, in the long term, what is the efficacy against infection, symptomatic documented infection, which is very different from just a symptomatic infection where a person may not actually go to the hospital or get tested, and very different from asymptomatic where once again a person may not be even aware. So, documented symptomatic infection, and more importantly, this was my curiosity, the um, efficacy against hospitalization and mortality. So that is the data, very interesting data. I think it is bittersweet. There are some things that I think you would like in terms of protection, and then there are some things that are kind of on the weaker side. Before we look at the study, you have to make up your mind about um, what do you expect from the vaccine. So there are many groups of people who will be watching. There will be some who just simply say vaccines should not be there. So fine, I'm not going to be convincing you. Then similarly, there are a group who would say vaccines should always be there. And again, fine, I'm not going to convince you that there are going to be side effects as well, because there are some who say there are no side effects. Then there are going to be folks who are going to say there are side effects as well, there are protections as well. I want to understand what is that protection and where do we go from there. I have done in the past, there are about 1600 videos on this channel where we have discussed COVID's pathophysiology, COVID side effects, COVID's outcome, vaccines benefits, vaccines risks, vaccines side effects, the cardiovascular side effects, the clotting side effects, the neurological side effects, the long COVID, the vaccine injury. So all that is covered. I cannot cover that again within 10-15 minutes. So I want to focus on this study. Today, we will also look at a new term that this study would introduce, and that is the predictive indexes or predicting indexes. So just like we have confidence intervals, we have predicting intervals as well. So we'll talk about that too. So let's start. This is the study that we're going to look at. The study is in the Lancet, Long-Term Effectiveness of COVID-19 Vaccines Against Infections, Hospitalizations, and Mortality in Adults, Finding from a Rapid Living Systematic Evidence Synthesis. Very interesting, and meta-analysis. They call it rapid living evidence synthesis. The reason for that nomenclature here is that number one, it is not a complete, thorough, systematic analysis. That means they didn't take up all the vaccine studies and put them together. That is why it is a rapid analysis of some studies, number one. Number two, living evidence synthesis is because they are, I believe, they are taking up data every week or every month and then adding it to the previous data and updating their numbers. So that is a living synthesis. And I believe this data is now being produced with the help or with the approval of Canadian health authorities as well. And this data is available on the authors' sites too. Plus, it is a meta-analysis. So they have the meta-analysis of multiple studies, and then they keep adding to that as more data becomes available. So very interesting method. So now before we go into the study, this is drbean.com. If you have not become a member of drbean.com, then what are you waiting for? Become a member. This is now we are really at the end. I've been saying since January that we're going to move to courses, and I am pleased to announce that our courses page is actually live now. So this is a courses page. This page still is being tested. It is live on production. It does not yet bring you to sales. So we are still updating the thumbnails and the package plans, etc. But you can actually see for various courses, if you click them, you can see what are the videos that are part of the course. Currently, for that low price, all of those courses are actually included in that price. It's unbelievable. But anyways, we are now testing this. This is on the live. If you go to members.drbean.com/catalog, you can see this course page. If you would like to test it as well, please test. Purchase is yet not working, but courses and the videos that are participant in those courses are present. So this is our progress. Hopefully in another week or so, we will attach it to the payment systems too, and then we will start soft switching towards the courses. Okay, now, and if you wanted to take advantage of the current offer, which is kind of almost free, then the links are in the description. Okay, so these are the gifts for humanity, and they're continuing. This is a study. I just showed it to you. I want to read the findings first, so that if you just want to say, all right, tell me what is it that they found. And I want to understand how you see these findings. So let's start. What they did was they said we screened 16,696 records at the title and abstract level. That is 16,696 studies. They pulled their titles and they pulled their abstracts. Then out of all of those, they appraised 832 5% studies full text as well. I think that we should just give it to ChatGPT and ask it to analyze them. And initially included 73 studies, is 0.4% of the overall studies. Of these, we excluded 7% studies because of the critical risk of bias, leaving 68 or 93% of the 73 studies that were extracted for analysis. So you could say that why did they not have all of the 16,000 studies in it? The reason for that was that many studies were weak and their data was biased, or their data was incomplete, or the data was too small, or data didn't have the intervals that they were looking for. What they were looking to do was, what is the immediate efficacy of a vaccine versus what is late long-term efficacy? That is why the title, the long-term effectiveness. So I will once again kind of tickle your thought for a second to say, make up your mind that do you expect a vaccine to protect fully from an infection? What people had promised is their issue. That's not my issue or your issue at this time. That is a political problem. They need to figure it out and they need to come clean on that. The question is, do we expect these vaccines to protect against infection? I would have loved to have a vaccine that can protect against infection. I think most of the time that will be more mucosal type vaccines. So again, we don't have them. So that is a discussion out of the window. The second thing that you have to make up your mind is what kind of effectiveness for long COVID. That data is not here. Then what kind of effectiveness against hospitalization and mortality? What matters to you? And once again, you could say nothing matters to me. I just don't want to hear it. In that case, this will not be a talk for you. So now let's see. For infections caused by SARS-CoV-2 strain, any SARS-CoV-2 strain, and it is very interesting, they actually looked at the vaccine effectiveness for Omicron separately, and then all strains separately, and that is a very interesting data point. Vaccine effectiveness for the primary series reduced from 83%. Now, before I continue reading this, another very important thing is they did not use US's threshold for effectiveness. Remember, our thresholds were 67%, then they became 70%, then they became 73%, then 80%, 90, 93%. They used WHO's definition. So WHO has had, for example, against documented symptomatic infection, they had said 70% effectiveness. And for death, hospitalization and death, 90% effectiveness. And then they had lower margins as well. I'll discuss that. So this meta-analysis and the living synthesis has used WHO's definition and not US's definition. So just keep that in mind too. So back here, vaccine effectiveness for the primary series reduced from 83% and the confidence interval 80 to 86 at baseline, and their baseline was 14 to 42 days. This was the baseline. So that was they called it immediate outcome. To 62%, and the range is 53 to 69 by 112 to 139 days. This is for the primary series, and they actually discuss the boosters as well. This is the primary series, and its effectiveness for symptomatic vaccine, symptomatic infection. Vaccine effectiveness baseline was 92%, which is 88 to 94 confidence interval for hospitalizations, and 91% for mortality, 92%. So WHO's threshold is 90%. So you can see that these are kind of meeting that threshold. And reduced to 79%. Now that is below the threshold, but I would explain that they also have up to 90% is the required, but the confidence interval's lower margin can be up to 70%. So 79%, 65 to 87 at 224 to 251 days for hospitalization, and 86% and 73 to 93 at 168 to 195 days for mortality. In my opinion, that is actually very good. And that is what I expected from the vaccines, that the protection from severe disease and mortality should be present. I never thought that these vaccines will be able to protect from infection. Still, that is a measurement. The infection is then connected to long COVID as well. So now we have done that study as well from US's Veterans Affairs Hospital, that vaccines effect on protecting from long COVID, I think was the reduction was just 15%. So that was the percentage of reduction. Okay, back here. Estimated vaccine effectiveness was lower for the Omicron variant for infection, hospitalization, and mortality at baseline. So what are they saying? That these vaccines against Omicron at baseline, which is 14 to 42 days, effectiveness was lower for all symptomatic infection or hospitalization or mortality compared with that of other variants. But subsequent reductions occurred at a similar rate across variants. So then after 14 to 42 days, when you look at multiple days, then the rate of reduction is similar. But it starts lower. So even when the rate of reduction is similar, it starts lower and continues to go lower. That is for Omicron. For booster doses, which covered mostly Omicron studies, so this is important to keep in mind. Booster data here is mostly for Omicron. Vaccine effectiveness at baseline was 70% against infection, 89% against hospitalization, and reduced to 43% against infection and 71% against hospitalization at 112 days. So for Omicron, and we had been having this information already, that vaccines, Omicron is escaping the vaccines. And so here you can see it starts a little lower, but then continues to go lower. Not enough studies were available to report on booster vaccine effectiveness against mortality. So their data is for hospitalization and for infection for booster, but not for mortality. So with this, continuing now, so that is the findings. So if you just wanted to know what did this study say, if I summarize it in my head for my own self, what it said was good protection in the beginning from infection or hospitalization or mortality, but as the days pass on, the effectiveness drops, especially for symptomatic documented infections. But for hospitalization and mortality, effectiveness stays high, reduces, but is better than against symptomatic as compared to against symptomatic infection. Okay, so now I'm going to go in some more detail. So if you just wanted to hear the summary, this is your summary is done. I'm going to go in the detail, and I'll also look at the limitations and strengths of the study. So study characteristics. It's a rapid living systematic evidence synthesis and meta-analysis. Canadian authorized vaccines only, that is messenger RNA, adenovirus-based vaccines. They did not include inactivated virus vaccines. Data that they pulled was from EM-base, USNIH search, then manual searches of various studies. And what they had done was they looked at the primary series, immediate, and as you can say, immediate is 14 to 42 days, and 112 days at least. There may be studies included that were more than 112 days observing the patients, but at least 112 days, so that they can create a long-term effect. Again, this study or meta-analysis is for long-term effectiveness, not for today or tomorrow. Then they also looked at booster, and they looked at the data, or they included those studies that had at least 84 days of observation after the booster. Effectiveness adequacy measure. So what is it that they were measuring with? So that is WHO's definition. This is different from US's definition. So definition was for symptomatic infection, WHO said that 70% should be the effectiveness. However, the confidence interval, so remember we write these numbers like this. We say, well, 70% effectiveness and then 95% confidence interval ranges from, let's say, 60% to 83%, right? So you're used to seeing those numbers. So WHO said that the top number, the actual number, is 70%, and the range, the lower bound of the range has to be 50 and above. So that was their definition for the effectiveness, for an adequate effectiveness of a vaccine. So the word adequate is added. So 70%, and the lower 95% is 50. For hospitalization and mortality, WHO's definition is 90% effectiveness, and the lower 95% confidence interval should be 70 or better. That is the definition with which they were measuring the studies. So as I said before, 16,696 studies, 832 full text, 73 initially included, 68 finally extracted. Others had biases, so they dropped them. And then the data was from 23 countries. And now before I continue, I want to explain the prediction interval. Just like confidence interval, which says that here is the base number, but the 95% confidence of being within this number, here is the range. So from, let's say, 70 to 83. Similarly, there is a prediction interval as well. And that prediction interval explains that if this meta-analysis results can be used to predict the outcome of other studies or other future events in the related context. So could you take this analysis and then predict that, hey, we think that if people are getting vaccinated, here is the outcome. So they said the prediction interval was very weak. What that means is that the data from the countries it is picked up, these studies and these statistics can apply to these countries, but cannot be generalized to the countries outside of this context. So imagine if the country involved is US or Canada. I'm just giving you an example. If you take this analysis that includes data for US and Canada, then the question is, can you use this data to predict what will happen, let's say, in France? And so if the prediction interval is low or it is a wide range, then that means you cannot. And their prediction intervals are wide ranging. That means these are not generalizable data points. So that is a weakness of this system. So 23 countries data, 53 were published peer-reviewed studies, 15 were preprints. And it is interesting, they said most of the preprints that we had were for vaccine effectiveness with Omicron, and most of the preprints had lower vaccine effectiveness that they were showing, and they conjectured that that is because it is more preprints were from the Omicron time. Now, this is a very interesting graph. There are a few tables and graphs that are interesting. This is, I believe, one of those. So here, the way to look at this one is, this is the WHO's definition for symptomatic infection, that 70% effectiveness is the cutoff point. This dotted gray line is the lower bound of 95% confidence interval. These lines here have this dot is the effectiveness, and then the upper and lower here are the confidence interval bars, or this is confidence interval bar. So if you see here, any variant, and down here is the number of days passed. So any variant within very few number of days, I think they have them here, 0 to 13, 14 to 42. So 14 to 42, this is a good point. And then the second one is 112 to 139, this one. So these two are important things to consider. So if you see here, vaccine effectiveness, immediate effectiveness, if you see this group of dots, this group of dots shows various studies and their effectiveness as they showed. And then this blue bar here shows the vaccine's meta-analysis of that effectiveness. So for example, here, this one for Omicron, this one is for any data. So let's start from the any data. That means all variants. So here, effectiveness is below 70, but the confidence interval is above and below 70, and it is above 50. So you can say that within the first few days, any variant in the vaccine, good effectiveness. Then, if you look at Omicron, you can see that the effectiveness is actually below the WHO's threshold, and even confidence interval is kind of reaching 50, so less effective, symptomatic infection. And if you look at this one, this is 112 days after. Any variant in the vaccines, you can see that the effectiveness has actually dropped enough that it does not touch the WHO's threshold anymore. It is below 70. Seems to me 68 or so. Actually, not 68. It is here, so probably 60. And the confidence interval is also below the threshold range, but the lower bound is still above 50%. So here, is it effective after this many days? According to the WHO's definition that they used, one part is and the other is not, so it is not. If you see for Omicron's bar has actually dropped even below 50% effectiveness. You can see that the upper bound is just touching it. This is the effectiveness. This is the lower bound. Omicron and the vaccines for long term, that is 112 days or so, the symptomatic infection effectiveness almost drops away from the WHO's definition. Then as you see the other days, You can see the days here: 140 days, 168 days, 196, 224, 252, 280. So almost a year here. If you see here, this is what is happening almost a year later. So this is the data for symptomatic infection. Even more important is the data for hospitalization and death. And I do not know why they decided to have green color for the death data, but anyways, that's for us. So hospitalization. So once again, if you see here, immediate 0 to 13 days protection is this black solid bar is 90% effectiveness, and then this is 70% effectiveness. That is the definition of WHO. So these two bars. So this one is above the two bars. So within 0 to 13 days, very good. Then 14 to 42 days, effectiveness, again, good against hospitalization and death. Then 112 to 139 days, again, staying within the definition. And as you see, as the days continue to pass, it does go down, but really slowly. And where you do not see the death data, that is just because they don't have that data for those studies over here. So this is encouraging that the protection against hospitalization and death continues to be there for a longer period of time. This one can, so again, I had requested you to make up your mind that how would you like to see this? For me, infection which does not degrade towards severity and hospitalization and death is better than hospitalization and death. However, long COVID data is not here. So that is a question mark for me. But of course, you can't expect everything from every study. So I can't blame them for providing this data. Then Omicron. Omicron documented infection, and there is a table, I'll show you that table. 14 to 42 days, Omicron 67%. So below the WHO's definition. And the 95% confidence interval is 53 to 77. So 53 is above the definition. So still less effective, slightly less effective than WHO said. Their predictive index or interval, if you see here, 0 to 89, that means these studies data cannot be generalized for other countries or out of this context. For example, the context will be socioeconomic status, geographical status, other such measures. So 0 to 89 is almost like nothing. It's not predictive. Although the ranges are still within the good interval, but that means this data applies back to the same countries whose data is being used here. 140 to 167 days. Against Omicron, symptomatic infections effectiveness falls to 32%. And look at the confidence interval, 2 to 53. So this is no effectiveness. I mean, even by the WHO's definition. So this effectiveness against Omicron, 140 days after to 167 days after the vaccination, primary series is just, this is what it is. Now, they didn't have the mortality data after 112 days for Omicron, and Omicron was more recent. Plus, there may be more studies that are still going through the process of publications. Hospitalization data they had, and they had it for here. So 14 to 42 days hospitalization, 72% effectiveness. Remember, the effectiveness definition was 90%. 72%, so already below, but still 72%. 95% confidence interval, 58 to 81. And predictive index or interval, 32 to 88. So once again, that is such a broad range that it is not applicable to out of this context, these countries and these socioeconomic statuses and these demographics. So this still 72% effectiveness is effectiveness, but it is below the definition. And they didn't have the data further down in the days. So here they say in their manuscript, they say, our analysis found very high level of heterogeneity, meaning the various studies that they included, they had a lot of diverse numbers or effectiveness data in them, indicated by I2 and estimate and sigma estimate. And 95% prediction interval, so this interval that we were discussing, such heterogeneity can undermine our confidence in generalizing from the estimates, even those with relatively narrow confidence intervals. So even if the confidence interval is very good, which means all studies are converging on that point and they're all agreeing that this is going to be the range, even then, because predictive interval is broad, these are not generalizable. And they give an example. For instance, our point estimate for the vaccine effectiveness of primary series against infections for any vaccine and any variant was high at baseline, 83%, at 14 to 42 days, with narrow confidence interval of 80 to 86. This finding indicates high confidence that on average, studies converge on this point estimate. So all studies are kind of reaching the same conclusion, that 80 to 86%. However, the 95% prediction interval range was 38 to 95, indicating that predicting the results of any given new study would be difficult. For example, predicting vaccine effectiveness in a new context, such as in a country not yet represented in this data. So this is very important takeaway, that the study is there, it is showing effectiveness. In some cases, lower effectiveness, in some cases, more effectiveness, but still, neither the lower effectiveness can be generalized nor the high effectiveness can be generalized outside of these 23 countries' context. And US and Canada are included in that. So then this is the last slide. So before I read this discussion of theirs, one paragraph from the discussion, which I thought was very interesting, I just want to once again say asymptomatic infection is not covered. And they mention that in their list of weaknesses or limitations. Similarly, long COVID outcome is not reviewed. That would also mean that some of us will say, well, vaccine injury outcomes are also not included. So that is true as well. So discussion. We found that the vaccine effectiveness of primary vaccine series against SARS-CoV-2 infection begins at an adequate level, as defined by WHO, of 83% at 14 to 42 days after series completion, primary series. However, vaccine effectiveness decreased significantly by 112 days after vaccination, reaching 47% by 280 days after vaccination, well below an adequate level. For COVID-19 hospitalization and mortality, vaccine effectiveness levels were also adequate at baseline, again 14 to 42 days, greater than 90%, but similarly reduced 112 days after vaccination, although vaccine effectiveness remained high over time, greater than 75%. When looking at Omicron-only data, we found similar waning patterns, except that the baseline levels of vaccine effectiveness did not reach adequate levels of infections or hospitalization. So decay rate or effectiveness reduction rate was the same, but the baseline, the starting point, was already below the definition of effectiveness. Then, what might be driving these Omicron patterns is unclear, whether a degradation in immunogenicity, changes in public health measures, variations in case numbers, general transmission, or a combination of all of those. Although boosters might be promising at re-establishing some protection, our results found that the vaccine effectiveness of boosters at baseline 7 to 28 days after receiving booster were still, albeit by a small margin, below the WHO's recommended levels, and in long term, these numbers reduced further. Our booster dose estimates predominantly represent mRNA vaccine against Omicron, which reflects the situation in many countries. collectively, these data suggest that vaccines are providing reasonably stable protection against hospitalization and mortality over the long term, but the protection against infection is more modest. And I think that is a summary as well. Although, if you now go back to the study itself, here is a study. If you look at the study, they would actually be discussing this for a longer manuscript. I mean, they keep going and discussing. This is all their discussion. So there are much more points. They also discuss their limitations and their strengths as well. And I would request you to look at that. Now, I just want to quickly look at one last thing, and that is somebody said that did they cover adenovirus-based vaccines too? So yes, they did. So vaccine effectiveness, if you see here, and the effectiveness above these tables, here, any mRNA vaccine, any variant, and then any adenovirus-based vaccine, any variant. So adenovirus-based vaccine, so this first column, I believe, if I go here to the top, this is 14 to 42, the second column, and then 112 to 139. So these two columns are interesting. So if I go down here, adenovirus-based, documented infection within 14 to 42 days, 69% protection, and then within 112 days and after, 56% protection. Then, and the predictive index is 15 to 83, very broad, so not predictable for other studies out of those contexts. Hospitalization, adenovirus based within 14 to 42 days, 90%, and then it drops to 89% in 112 days. And as you can see that even after 85%. And this K over here represents the number of studies that were participant in this data analysis. Then mortality, adenovirus-based vaccine, 84% effectiveness at the beginning, 14 to 42 days. Then they didn't have much data for 112 days. And then I believe the next one, 75%, 95% confidence interval, 53 to 86. So what is this third column? The third column is 140 to 167 days. So that is the number, and I would request you, the links are in the description, please see what are the things that are of your interest and look at that data. It is interesting data. This is for the first time I'm seeing this data put together, which is good. And then here is their PDF, and then this is their website where they have some of this data, plus they have trainings and tools, and I believe this living synthesis is present somewhere over here as well. So this is the discussion. Do me a favor. I did 38 minutes, so that was fast for me. Like, subscribe, and share. And if you would like to support this work, there are links in the description. You can support it by becoming part of patrons. You can support it by becoming member on the YouTube channel, especially the Luffy Zooms membership also has the Zoom calls, and then Substack as well. And this brings me to the announcement for tomorrow. So tomorrow I will have two Zoom sessions, one at 1 p.m. Pacific, and the other one at 6 p.m. Pacific. That is why I will not have the YouTube session tomorrow. And in these two Zoom sessions, we will discuss the voted study or voted topic that the supporting beans have decided. So 1 week we decide what topic to discuss, and the next week I get time to prepare for it. And then there'll be two Zoom sessions tomorrow that I will present this data in. So tomorrow I will not be on YouTube, but I'll be on Zooms. So with this, thank you very much. Love you all. Stay safe, happy, and healthy. I would see you on Friday. I believe I'm going to resume the berberine series on Friday and continue from there. I wanted to make sure that this study is in front of us. Thank you very much, and bye for now.